like we have a bit of a small group today, but that's all right. I hope that you are staying warm in this extremely cold weather that we're having. So you kind of know the drill, but obviously if you have questions, feel free to write them out. We can address them afterwards. And so with that, I'm just going to hand it over to Catherine.
Okay. Good morning, everybody. I am sorry that I'm a few minutes late. We've had a lot of weather here in Buffalo. And anyways, I had to drop my son off. So today's talk is on schizophrenia and other psychotic disorders, and we'll be looking at them and some of the issues that coexist. In this webinar, we want to be able to discuss the importance of standardizing care, discuss a plan for intervention, what standardized assessment tools we would use, structure interventions, the use of the teaching tools, talk about medications, and most importantly, their side effects and what they do to the person with Alzheimer's, discuss the value of telephone follow-up. So schizophrenia, just as a review, is a disease of the brain. It generally affects about 1%. Research, it's basically about 1 to 1.8% of the general population. It's supposed to affect men and women equally and people of all racial, ethnic, education, and economic backgrounds. It's probably the most chronic and debilitating of all of the mental health disorders. Its onset is often in late teens, early 20s. And many times, you know, I always think back to a gentleman that I worked with on an inpatient unit. He had gone off to college his freshman year, really bright young man, played the piano unbelievably well, was very talented. I can't remember what school he went to, but it was one of the big music schools. And when he got to school, he started really having problems, and he got very anxious. He thought people were talking about him. He stopped going to classes because he was worried that, you know, people might be following him, and it was very strange. None of this had happened, and by about Thanksgiving time of that year when he came home, his parents were just shocked to see him. He had gone to some doctor had actually given him Xanax. And at this point, he was taking about 6 to 7 Xanax a day. And it obviously wasn't working to get rid of hallucinations, but he was hospitalized where I worked in New York City. And after the course of probably it was about a week or two, he was diagnosed with schizophrenia. But he had become socially isolated. He had a lot of the kind of negative and positive symptoms of schizophrenia that we'll talk about. And I just remember it because he was, you know, just in the kind of beginning of his adult life. So as I mentioned, it's often in late teens, early 20s, periods of remission and exacerbation, and there really is no known cure. There's a lot of theories on what causes it: genetic, biochemical dysfunction, physiological factors, psychological factors. There was a theory called the stress diathesis theory, that it was a perfect storm of physiology, stress, and unhealthy relationships that kind of tipped the balance for those at risk for this disorder. One of the other things I actually kind of observed over the years was in young people, sometimes I had 2 clients who I had taken drugs, some kind of hallucinogenic drug, in their early 20s, usually in college, or maybe they weren't in college, and went on to develop symptoms. And I remember saying to them, my boss at the time, who did a lot of research, did those drugs cause it? And they'd say no, but it's just kind of sometimes that tipping point. So it was very interesting. It's not a multiple or split personality. Schizophrenia is not caused by bad parenting. There used to be a theory called the schizophrenic mother, not a result of childhood trauma. On the bottom of the slide there, you can see a normal brain and a brain of somebody with schizophrenia. There's definitely a lot of brain involvement, and so we know that it's a brain disease. As I mentioned, the onset in males is generally 18 to 25 years old, and females 25 to 35. If you compare males to females, males have more negative symptoms. That negative symptoms are, we'll talk about, they have a poor prognosis, they have more hospitalizations, they don't respond as well to meds. Females experience more dysphoria, and they tend to be more paranoid, have more paranoid delusions and hallucinations. So what is schizophrenia? It's a psychotic disorder defined by the presence of psychosis, and it's a state of mind in which the person's ability to recognize reality, interact, and communicate with others is impaired, greatly impacting that person's ability to deal with life's demands. And many times, again, they don't know that their reality is altered. We know that, as the care provider or the family will notice it many times. Schizophrenia and the criteria for it changed in the DSM-5 a little bit. DSM-5 used to categorize schizophrenia into types: paranoid type, disorganized, catatonic, and undifferentiated. Now it's called Schizophrenia Spectrum and other psychotic disorders. So the person has to have 2 or more of the following symptoms during a 1-month period, with some of the illness persisting for at least 6 months. They have to have delusions. Those are those false beliefs, hallucinations. They can be auditory, visual, disorganized speech, not coherent. Many times they're grossly disorganized or catatonic behaviors. They have negative symptoms, negative symptoms are those symptoms that should be present. So we'll go through those: social, occupational dysfunction, and the duration. The duration has to be that the person has experienced this for at least a month, but other symptoms for 6 months. So it's not something that a physician sees and just diagnoses right away. Schizoaffective disorder, which really is another common disorder, and one of the big changes to schizoaffective disorder. Schizoaffective disorder is kind of the combination of a mood disorder and a thought disorder. And the biggest change in DSM-5 to schizoaffective disorder is that a mood disorder must be present for a majority of the time the disorder has been present in the person. It's diagnosed in 11 to 19% of younger patients with mental illness. Sometimes, for a couple of years, it was kind of the diagnosis of the day. We were seeing a lot of this. And I think it's sometimes diagnosed earlier because people don't actually know what they're dealing with and what the person actually is exhibiting. And so it's the person may not exactly have full-blown symptoms for schizophrenia, and that can be an issue. So they will give the person a diagnosis of schizoaffective disorder. So how do we diagnose schizophrenia? It's important to obtain a detailed patient history. There's no blood test or test. It's really a mixture of signs and symptoms that fall into 2 categories that are observed. The assessment tools that are used often to diagnosis in a patient is, for the doctor, it's an interview. If they're in a research institute, they might do the brief psychiatric rating scale. They might also use some of the other assessments that we use. They may assess them for depression using the GDS, or usually they're going to be younger people, so it's going to be the PHQ-9. Obviously, if they have symptoms of any kind of, neuroleptics use and they're stiff, they may have an Ames gun on them. Their suicide risk would really be assessed, because this is a population that's at a great risk for suicide. And they may check their cognitive function, especially if it was somebody later in life. It's crucial, though, really to rule out what could be other causes. So the things that, this is one of those diseases where they rule out other symptoms before the diagnosis is made. Is there any, does the person have any brain tumors? They usually do a brain scan. Is there any kind of drug abuse, LSD, amphetamines, marijuana, alcohol withdrawal, any kind of delirium that can look, have psychotic symptoms, or tertiary syphilis that gets to the brain. So they really need to rule out a lot of the physiological things that could be going on as well. And that's why I mentioned this can take a while to actually give somebody the diagnosis. So these are patients that exhibit positive and negative symptoms. I just want to talk about that. So positive, those are present but should be absent, and they're an excess distortion of normal normal function. Negative symptoms are those that are absent but should be present. And then there's cognitive dysfunction, diminished executive function and working memory. One of the things I always like to tell people when you're working with this population is there's a similar relationship to cognitive impairments in that people process information slower. It can actually take the person 60 to 90 seconds to process something, and that's why people will think that they're just not processing something, and it's actually due to the schizophrenia where it takes them longer when you've asked them to do something or you're communicating something to them. So we need to know that when we talk with somebody with schizophrenia, that we need to be more patient. So let's kind of go through those positive symptoms. The positive symptoms are really the delusions, the erroneous belief, and common themes are persecutory, I don't know why I can't talk this morning, are really the most common. Patient believes he's being tormented, followed, tricked, spied on, the TV's talking to them, or referential delusions, or comments in the paper and songs on the radio or TV are directed toward them. And then there's hallucinations, which are those false sensory perceptions experienced as voices, sometimes where the person may hear somebody familiar or unfamiliar. They may be threatening. Threatening is most common, but they may not be. There may be two or more voices that they hear conversing. They could be voices making comments about the person. So how do we want to respond? Or they could be things that that person is saying. Now, the gentleman I mentioned that I saw in the hospital that was a young college student, he was actually seeing things. He was seeing things that weren't there, and he was also hearing voices that were telling him he was bad. And so when we're working with someone like this, how are we going to respond to them? We want to say to them, I don't hear the voice, but I believe that you're hearing the voice. Never discount the person's experience. We need to know if the voices are threatening, are they commanding, are they telling the person to harm? Because if they are, that patient is at great risk, because many times that's what will drive someone and lead someone to suicide. Negative symptoms of schizophrenia is the flat affect. The person appears immobile, unresponsive, and has poor eye contact. So it's just a person that you look at and there's really no facial responses. They have anhedonia, which is really lack of pleasure, no pleasure. This and some of the other characteristics often trigger suicide in somebody. They have an asociality. They may spend much of the time alone where they feel safe. They may feel that way because of delusional thinking, but they many times feel detached and uncommunicative, and they don't feel like they really relate to others. They have something called alogia, which is a brief, empty replies due to decline in their thoughts. Now remember, I mentioned that it takes them longer to process things, so many times the alogia, the empty replies, or the time it takes can be due to that processing. They have avolition, which is lack of energy and drive. It's difficult for them to complete simple tasks. Often they're able to do little more than sleep. And I think some of this actually also has to do with the medications they get put on. I know everybody says this is part of the disease, but I know in this gentleman that I worked with, I mean, I know his family said to me, after he was on meds, he just didn't seem to have the energy or the drive that he did previous to that, which was a combination, I think, of his psychotic thinking, but also his real, response to the strong medications he was on. About 50% really of all people with schizophrenia have mood disturbances and are depressed. 20% attempt suicide, 10% complete them. This is generally not a population of people that live late in life. They don't have, their longevity is shortened, and it's usually shortened because they're at a greater risk for suicide. And it's also shortened because the meds they take The antipsychotic medications really put them at a risk for certain metabolic syndromes that we'll talk about. And so they have cardiac disease and they have diabetes, and these are all things that, can put them at risk health-wise, and they're just another thing that becomes more challenging for that person to manage. They often feel a sense of hopelessness and have suicidal ideation. So this is a population, when we're taking care of them, we need to thoroughly assess their suicide risk. We need to really assess, have they attempted suicide before. We want to make sure that we're really assessing that in this population and doing it on a frequent basis. This population also can have cognitive impairments. They can be forgetful, distractible, have trouble with decision making, problem solving. Their thinking is very concrete, and they can have a hard time interpreting things, and that's all part of the disease. And again, if we're working with somebody that's elderly who has schizophrenia, their level of cognitive issues could be greater. So what are the theories regarding the etiology? That there's anatomical abnormalities, that there's enlarged ventricles, the brain is smaller, there's a decreased hippocampus, and the hippocampus plays a role in memory and learning. The hippocampus is what takes all our short-term memories. Like if you're listening today to me and you remember anything, it's being processed through your hippocampus. Now, interestingly enough, when we teach our Alzheimer's program, we always talk about the hippocampus is the first area of the brain affected with Alzheimer's, and that's why people hear that person repeating all the time, telling them the same stories, and that has to do with that part of the brain. There's also a dopamine hypothesis that plays a role. The dopamine plays a role in movement, emotion, motivation, feelings of pleasure, thinking, and that there's lower dopamine. So lower dopamine treats symptoms of schizophrenia. So people have less of that chemical. There's other neurotransmitters that are implicated, serotonin, norepinephrine, glutamate's getting a lot of press and a lot of research done on it, and GABA. Conventional antipsychotic medications lower brain dopamine levels, therefore treating the positive symptoms of schizophrenia. And again, those positive symptoms are those ones that are present but should be absent. Schizophrenia does run in families. Twin studies show that there's a 50% risk of developing the disease in monozygotic twin of a person with schizophrenia compared to 1% of the population. And so, there is a hereditary risk with this disease. So how do we manage schizophrenia? Well, I think our number one thing that we always want to focus on with this population is safety. As I mentioned, a significant number will commit suicide. So we always must assess that person for command hallucinations. We may need to initiate suicide precautions, or we may find right when they get referred to us, they're really not great to be at home if they're at any kind of suicide risk. So they may be too risky if you get a referral. In an outpatient world, cognitive behavioral therapy is used in a younger population with this, where it's been shown with meds to have some effect. Patient and family education, and we need to think about what would we want to include in the education, medication management, and what are the major issues with that. Well, one of the big things is compliance. This is a population who many times doesn't take their meds. They don't take the meds because they don't make them feel good. They have side effects. The person doesn't feel particularly great on these medications. So, again, this is something you want to address with that person and look at. Management of schizophrenia, psychosocial rehab, and with that, it's structured to provide support. And whatever's on here are things that we can do. We can provide support. We can help the person provide structure. We can encourage them to any kind of vocational and social skills training. Obviously, that would probably not be in the home unless you're bringing in OT. You can enhance socialization, teach life skills to assist the patient with managing themselves in the community. What are some other behavioral techniques? Well, I mentioned outpatient. Sometimes CBT is done with this population, but a lot of the population, the focus is on stress management, helping these people cope from just a day-to-day basis, manage their life, problem-solving skills. Communication is often a big thing. I remember working with a woman who had schizophrenia in the home, and when I'd get to her home, she'd always say to me, I want you to call my doctor for me. I want you to do this. And so a lot of what I did when I worked with her was really trying to get her to do some of these things herself, and I'd have her do it with me there with her. And she was often afraid that people wouldn't understand her or want to make fun of her on the phone. So I would do these things with her. We'd put together a list. And actually a lot of the time, once she did these interventions, then what I would focus on with her is really giving her a lot of positive feedback. Oh my gosh, look at you really did this, you did it well. Everybody understood what you were talking about, so that, I was able to kind of give her that sense that she was, doing things. So communication skills is huge. Problem-solving skills, they're also huge. So these are things we need to focus on. With this population, the learning of maladaptive responses to problems is often the result of cognitive distortions or making mistakes in assessing cause and effect, which is why cognitive therapy and behavioral therapy are often combined, and individuals with schizophrenia often make incorrect assessments of what causes something and then what the effect is of that. And so I think one of the things we want to do with this population is the more we can help them be organized, structured, the better off it will be. They often don't learn as well from experience because of their disordered and disorganized thinking. If they have a bad interaction with someone or somebody is unpleasant to them, they always think it may be something they caused and it's a response to them. That person doesn't like them, or they didn't, they're not good, or they're not nice. So we need to keep that in mind. Management of schizophrenia, these was the things that I mentioned, but things we want to do is teach life skills to the patient to assist with managing themselves, enhance their socialization. These are things that are all provided in psychosocial rehab that we can, as I mentioned, do at home. So what are some coping guidelines for the family? Well, family therapy can significantly decrease relapse rates for the person with schizophrenia. In high-stress families, schizophrenic patients are given standard aftercare relapse 50%, and relapse will occur 50 to 60% of the time in the first year they're out of the hospital. So things that we can help do is establish a daily routine for the patient to follow, help the patient to stay on medication, and encourage and educate the family members why we want them to take this medication daily, just not when they're experiencing a hallucination or a delusion. We want to keep the lines of communication open about problems or fears the patient may have, letting them know that you're there for them, and you understand that they're going through a hard time. Understand that caring for the patient can be emotionally and physically exhausting. We want to let the families know that. We want to encourage them to take time for themselves. We want to keep the communication simple and brief when speaking with a patient. We don't want to give somebody long, drawn-out, complicated explanations of how to really do something. This is not the population that works well with that. And so it's not something we're really gonna do with a person with schizophrenia. We're gonna be patient and calm, and encourage the families that they ask for help and join a support group. So what kind of psychotherapy works with this population? Well, there should be a focus on insight, because insight therapy is really not going to be helpful with this population. Because they lack a lot of insight into things and also see things differently in the world. So what can we do? We want to focus on their medication. We want to focus on their learning in social skills. We want to support the person's weekly goals and activities. And with this population, it can be very helpful to, from week to week, set up some goals with the person with schizophrenia. As simple and easy as they may be, it's very helpful, and then it can reinforce when they do them that they're moving along, and it can be a way for you to establish, you know, with them that they are actually doing things. Reaching out to them can be helpful. They need skills, you know, with basic management. If they're younger, if they're older, it may be looking at whether they need support for their ADLs and cooking. They also many times need help communicating with their family, work, making phone calls. And so we want to think about how we can foster that, how we can help that person maintain those skills, and what we can do. Again, thinking that, you know, it's basic things that many times that they're going to need assistance with, and you know, if we can empower them a little bit, it's going to help them be more independent and function at a higher level. This slide just looks at some of the cognitive therapy ideas that people with schizophrenia, there's a misinterpretation of events in the world, and cognitive therapy requires accepting that cognitive distortions and disorganized thinking are produced by a biological problem that will not change from the correct interpretation of reality. So basically what it's saying here is a lot of people, CBT, when people are outpatient, challenges them because lots of times they don't recognize their symptoms as having a biological cause. And the goal is to help the client use information from the world, their perceptions, and for people to challenge them. If you're seeing elderly in the home, and again, if they're, you know, in the Medicare ages, this is probably not the best thing because at this point people usually have some cognitive issues, memory impairments as they're older. So the learning of maladaptive responses to problems is often, as I mentioned earlier, what's the result of those cognitive distortions. So sometimes we can help them see things and help them learn from an experience. And so, you know, the goal of behavior therapy is about teaching them social skills. Our role in the home really should be focusing on what can we do, as I mentioned, to provide stress management, assertiveness, communication skills, problem-solving skills. At the point they're going to be an elderly in the home, it's the day-to-day management, and how are they managing other diseases they may have, diabetes, cardiac disease. So we want to focus on that. So I always say to people, think of schizophrenia as a combination of a thought disorder, a mood disorder, and an anxiety disorder. And so the management of schizophrenia may include antipsychotics, antidepressants, and anti-anxiety medications. Research shows that after the first year of treatment, 75% of people will discontinue the use of their medications due to side effects and difficulty to tolerate them. So we need to really be cognizant of that. Now, there's all these newer antipsychotics on the market that are supposed to have less side effects, but they still cause side effects. And this slide particularly is going to look at what are the elderly and with schizophrenia and their issues. Well, the first corner box looks at what are the causes of relapse in elderly schizophrenics. And there's a couple of them that I found over and over and over again in the literature. One was medication noncompliance, that they were non-compliant to medications. Another one was the death of a loved one or a caregiver death. Now they feel alone or isolated. They have new medical problems, and again, those may be brought on by the long-term antipsychotic use, or there's a depression. So we need to be acutely aware of these things as causes of relapse. Elderly schizophrenics generally have 4 times higher rates of tardive dyskinesia from chronic neuroleptic usage than younger patients. So again, we want to be completing an AIMS and really documenting where and what that, it isn't so important, as I mentioned earlier, to document a score on the AIMS, is where is the abnormal movement in their body and what is it. Schizophrenic symptoms tend to remain stable through relapse on medication in the elderly. New onset psychotic symptoms in the elderly patient are more frequently a manifestation of dementia, delirium, psychotic mood disorder, or substance abuse. And so this client, as I mentioned, that you might be working with, say if they're 70 and they've had schizophrenia since they were 20, some of the new symptoms may, as I mentioned, more be related to dementia. They have up to twice the risk of developing dementia than somebody without schizophrenia. And they often are people who have chronic lung disease. People with schizophrenia are usually have a higher incidence of smoking and may have smoked a lot of their life. One thing to be cautious of in the schizophrenic is they may become delirious due to medical problems, and the delirium may increase positive symptoms and produce behavioral problems. So we need to kind of be aware of that, because sometimes I used to see in the hospital what we thought was really an exacerbation of their condition was really a delirium. Person might have, a UTI or some kind of chemical imbalance or a thyroid disorder going on that was causing that increase in symptoms. So the psychopharmacology, obviously neuroleptics, the conventional meds were the older ones. The newer atypical antipsychotic medications are supposed to have less side effects. So the atypicals are risperidol, Zyprexa, Geodon, Abilify, Seroquel. Clozaril was a drug that, came out, well, I think it was many years ago. And I know it's still used for people that don't respond to other things. We have to be careful because it can cause agranulocytosis. So they have to have those weekly blood counts or white blood counts. But it can be incredibly effective. So we want to really look at what the person's on and their side effects. I don't see as many older people on the older medications, but I think it depends on where their prescriber's from and what kind of setting they've come from. The conventional older antipsychotics like Thorazine, Haldol, Prolixin, Thiothixine, they were all from the 1950s, and we knew that they blocked unimproved symptoms because they blocked the dopamine receptors, and they were more commonly used to treat those positive symptoms of depression, those things like the hallucinations and delusions, but they had serious side effects. They caused the tardive dyskinesia or the neuroleptic malignant syndrome, so we always need to be aware of that with that population. One of the things in home care, though, I think that I saw a lot of, and these were actually sometimes the reasons that patients with schizophrenia were getting referred to us, was they had twice the rate of metabolic syndrome. And what is metabolic syndrome? Well, the symptoms are things like abdominal obesity, insulin resistance, dyslipidemia, elevated blood pressure. And 60% of people with schizophrenia will meet the criteria for metabolic syndrome as opposed to 30% of the general population. They have 2 to 4 times the risk of diabetes, and typical neuroleptics may increase blood glucose levels. So we need to kind of look at that. Is this something that we're seeing? It also, these patients have an increased risk of cardiovascular disease and death. So these things, the diabetes many times, the cardiovascular disease, may be another reason this person with schizophrenia gets sent to home care and gets referred, and yet someone goes in and opens this case and realizes the person has schizophrenia, which alone makes it harder for that person to manage their meds, to remember to take them, to take their psych meds and to manage their blood glucose levels can be a challenge. So home care and education from home care can be really important. So what do we want to educate people with metabolic syndromes? What's really our role? We want to provide nutritional education. We want to talk to the person about the importance of the role, and especially if they're elderly, of moving and of exercise. They may not be able to do any kind of exercise that's aggressive. We may want to challenge, the fact that they don't think this is related to the medications. We want to provide weight management, reduction information, psychoeducation. We want to teach them why it's important to manage their insulin and keep it within, their blood sugars, stable, and why they need to monitor it every day. And if they're older, somebody like this, that has schizophrenia, we really want to write out these instructions and provide very simple tools to them to understand this. We want to talk to them about, I'm just thinking of a client years ago that I went in the home to see. On average, this woman was drinking those huge bottles of soda. She was drinking 2 to 3 of them a day. and she was a diabetic, and she didn't know it and at the time, and it was causing all kinds of problems. And we really had to educate her about the amount of sugar in that. Her doctor didn't want her to be drinking these, so it was really hard to it was like tapering somebody off of something. But again, there was a lack of education. I have to tell you an interesting story. When I first got into home care, in the program that I was hired to oversee, we also provided a program in New York State, so it was child and adolescent psych home care. And we got referred to us a client, a young boy, and he lived with his mother, and his mother had schizophrenia. And the child was 11, and they weren't exactly sure what the child really had wrong. Its chart kind of said ADHD, oppositional defiant disorder, intermittent explosive disorder, which were all common things we'd see in the 90s in kids when they weren't sure what was going on. We probably still see some of those today. But what's interesting, when the nurse Joe that I worked with went out to the home, and he was doing the history with the mom and the assessment and meeting the client, who he said was really a nice young man, but he noticed that this young child was really heavy. Not morbidly obese, but heavy. And when he talked to the mom about diet, I still remember this day because I remember him calling me and he said to me that in their kitchen, the only thing that this mother ate was Coke and Cheetos. And he said the kitchen cupboard that's what was there. That was really basically all this mother ate. And he had the feeling that this was the majority of what this child ate when the child was at home. When the child was at school, hopefully got something different. But it was really interesting to me. To this day, I still remember that case. It was very, very sad. The mother was very ill, and it was almost like this child was trying to take care of the mother. So it was one of the things that the nurse did was work to get this woman into kind of a group setting that she could be in with her child, this apartment setting where there was a case manager that worked with them regularly, because they had been living alone in a really kind of scary neighborhood. So he was able to help them do that. What do we want to look for? This is a population that gets a lot of side effects. So we want to look for those extrapyramidal side effects, any kind of dystonic reactions, the pseudo-Parkinsonian like symptoms, where they get a gait that's shuffling, the akathisia, the tardive dyskinesia, the neuroleptic malignant syndrome, where they, that person spikes and can have a rapid fever. And years ago, I read a chart, and a patient actually had neuroleptic malignant syndrome, and they thought the person had the flu. And it was a woman in her 50s. It was sad because she had to go to the hospital. She ended up in intensive care. Other side effect symptoms of the medications are sedation, weight gain, orthostatic hypotension, photosensitivity. So these are all things that we need to be aware of, and we really need to document if there's any of these kind of symptoms, again, in the chart from really start of care and throughout an episode. So the care guide for schizophrenia has an introductory letter. It establishes that partnership with that client. It has assessment tools that really look at, things that are looking at the geriatric depression scale, the SAD persons, the AIMS, negative and positive symptoms. So these are all things we want to document and evaluate in the client that we're caring for. There's several lessons in there that have an educational component, some of them that have an assignment to be completed between visits. Now again, with this population, if it's an elderly woman with or gentleman with schizophrenia, many times they'll have some cognitive issues. They're going to remember that, but it can be your next item you talk about and remember on the next visit. And so each, you can go through the care guide, you can teach people. Each step, some tools may take more than one visit, and it may take more time because you want to make sure that the person's teaching back to you, that they can verbalize what it is that they are being taught, and also how they're going to utilize the information. We want to teach meds from your EMRs because they're more current. We don't any longer really put teaching tools in the care guides for the meds because there's so many new meds and their indications and dosages change so frequently. So we think it's better for people to use the drug information today that comes out of the EMRs. One of the last things I want to remind you is don't forget to use the telephone assessment tool. The use of this tool increases compliance with the treatment plan, and it gives a powerful message that accompanies a phone call just to say, how are you doing? And I think people love to know that they're being thought about, but it also really has been shown if you're doing telephone calls, especially at the end of the week, Thursdays and Fridays, that it can cut down on your level of readmissions, hospitalizations, and ER use. And then again, if you see somebody that has warning signs, you can get out there and make a visit. So with that, Megan, I'm going to open it up to questions. And if one of the things that, I'd like you to think about is for all your patients that you take care of the holidays. And this can be a really particularly hard time of the year for somebody, whether they have schizophrenia, whether they have depression or bipolar. They may feel more isolated. They may feel hopeless, and reach out to your clients during this season, make a phone call, see how they're doing, be encouraging, let them know you're there for them. Experienced over the years is that when we do that, it makes a whole difference in how this patient is able to handle the holidays by knowing someone's there and thinking about them and reminding them to take their meds and to think about themselves and engage in positive things that you're teaching them. So hard time of the year for many people with mental illness. So with that, I'll open it up, Megan, if anybody has a question.
Great. At the moment, it doesn't seem like anyone's written anything. As a reminder, this has been recorded. I'll send it out. I'm actually right now.
Megan, I also wanted to remind everybody that the surveys that Megan sent out to you, if you could try to get them in to Megan today or in the next or beginning of next week, we're going to take a look and see if there's additional things that you all would like to learn or have as resources. And we would, we were thinking, we could kind of reconvene and have a discussion on things that you might find that your agency needs to help you on your continuation of providing behavioral health services.
And if you need me to resend, please just send me an email and I'll send it out. I am actually doing a staycation right now, so I won't be doing sending out the recording or really responding to any emails until Monday morning first thing. So just send me an email though, and I'll be sure to resend out the survey if needed. But again, does anyone have any questions at this time? All right, it doesn't seem like it, but as usual, always contact Catherine or Amy or myself or Verna with any questions. And so with that, Catherine, are you all set? Do you have anything else you want to cover?
Yep, no, I just wanted to wish everybody a happy holiday, and please feel free if you have anything you need to reach out to us, and thank you so much.
Wonderful. And yes, I would like to also wish everyone happy holidays. So thank you and have a great rest of your day. Stay warm.